Hello, everyone. My name is Dr. Raven Baxter, and I'm your host of this episode of the Raise the Line podcast. And I'm a molecular biologist and director of science communication at the Cohen Center for Recovery from Complex Chronic Illness at the Icahn School of Medicine at Mount Sinai Hospital. At the center, we work to advance treatment and knowledge of post-acute infection syndromes, including long COVID, tick-borne and vector-borne illnesses, myalgic encephalomyelitis, chronic fatigue syndrome, and connective tissue disorders like hypermobile Ehlers-Danlos syndrome. And post-acute infection syndromes, they're characterized by persistent symptoms that last for months or even years after the initial infection has been treated. And unfortunately, many of these conditions are often misdiagnosed and can lead to delayed treatment and prolonged suffering for these patients. And so, although we're making progress on our understanding in how to approach and diagnose and treat these diseases, there's still much to learn, and there's yet to be established a standardized treatment protocol for these illnesses. So today we have the privilege of hosting Dr. Mike Van Elzacker and Dr. Shannon Delaney. Both are very amazing leading experts in understanding the neuropsychiatric manifestations of some of these diseases. And I'm actually going to have you both introduce yourselves because I don't feel like the bio I have really does you justice to your accomplishments and your knowledge. So, Shannon, would you be okay with going first?
Sure. My name is Shannon Delaney. I'm a child and adolescent psychiatrist by training. But in reality, I see both. I went through a adult psychiatry residency program as well. So I see kids and adults. For many years, I've been interested in immune and infectious contributions to psychiatric disease. I did a research fellowship for 3 years, which is a NIH-sponsored research fellowship looking at immune and infectious biomarkers related to psychosis. And for many years, I was doing both research and clinical work at Columbia University Irving Medical Center. And last summer, I started my private practice in Manhattan. I focus on seeing a lot of kids and adults who have histories of Lyme disease and who have new onset psychiatric problems in the context of their infection or post their infection.
Thank you. And Mike?
Sure. So hi, everyone. I'm Mike Van Elzacker. I'm a neuroscientist at Mass General Hospital and Harvard Med. And I'm kind of a neuroimmunologist, I suppose. I'm not a clinician. I don't try to get patients better. I just try to understand what's wrong. And I focused on infection-associated chronic illness and was focused on that even before COVID hit. And then when COVID hit, we sort of knew it was going to be a big problem with long COVID, and that's exactly what happened. I'm also co-founder of the Polybio Research Foundation, which is a nonprofit whose goal and role is to try and facilitate often new groups that have good techniques and methods that are able to study these conditions in ways that haven't been studied before, but that would maybe lead to some answers.
Thank you both. And this podcast has an audience of medical students, and as someone who has been in the position of a patient with a post-acute infection syndrome, long COVID specifically, and then as a education practitioner working in this space at a medical school, what I'm hearing, I see such a disconnect between the understanding of how post-acute infection syndromes can have real neuropsychiatric manifestations that aren't your traditional interpretation of what that would be, like what it would be like to have, for example, anxiety or depression, or even just behavioral changes in general. I would like to dig into really the root causes of these, or if you can offer any insight to what we think is driving the manifestation.
So, yeah, I mean, the root causes of just neuropsychiatric conditions in general. So, yeah, I mean, the dogma, I suppose, that most people are taught is that most neuropsych consequences or conditions are a combination of genetics and stress, and that's sort of the baseline story. But then when you try to dig into the genetics part, it's never very much. I mean, there's a concordance rate of a little bit less than 50% among identical twins with schizophrenia. So it can't purely be genetics. They share inherited genotype. So there must be other factors, or it surely seems like there are other factors. It may be complex, but at the research side of things, we know that there are certain organisms that share molecular mimicry in surface proteins and things like that with important functional aspects of the central nervous system. So cross-reactivity between, certain, like a cyst from T. gondii, for example, and the NMDA receptor, they share size and shape so that antibodies against one will bind to the other. And that's a good clue for what might be causing, in some cases, severe sudden onset neuropsychiatric consequences. So I think it's a big area of research that the research, a lot of the research is there or really promising, and I think the medical side of things kind of needs to catch up.
Yeah, I would say I can kind of comment on two aspects from my perspective as a clinician. So in the chronic Lyme disease area, there's a big debate in the field about what causes ongoing lingering symptoms in patients. And the major debate is whether or not there's persistent infection versus immune dysregulation, like a post-infectious, purely kind of immune dysregulation or autoimmune problem. And I think we're pretty far from settling that answer, to be honest. A lot of the traditional infectious disease Society of America people, they really advocate that this is not a persistent infection, that you should get a few weeks of antibiotic treatment and you should be all good. The infection is cleared. I definitely am not sort of in line with that thinking, because clinically we can see people get much better when they're on longer term treatment with antibiotics. And what I would say supporting the idea that persistent infection is playing a role is that when you do animal studies involving mice and also monkeys that have Lyme disease, and you give them Lyme disease and then you give them quote unquote appropriate treatment, and then you wait a few months and sacrifice those animals, you can see evidence of bacteria all over their bodies in multiple different organ systems. And we also know from the in vitro data, and I'm talking about Lyme disease specifically, that you need multiple antibiotics to completely eradicate the infection. So most of the studies in both the animal models and the in vitro studies show that you need actually triple combination treatment to eradicate the Borrelia bacteria. And that's not how we approach things clinically from a treatment standpoint. So I think logically, if we see all these people who are super sick after infection and they're only getting a couple of weeks of antibiotic treatment at best, most of the patients that I see actually aren't diagnosed early. They're diagnosed years after their initial infection, and they're sometimes only given a few weeks of antibiotic treatment, and then they're still sick. So I guess the point is that I think that there's a lot of persistent infection at play. That being said, I also think that the persistent infection probably dysregulates the immune system a lot, because we do know that immunomodulatory treatment in the context of Lyme disease and in the context of other infections that kids get, such as PANS. We talked a little bit about PANS or PANDAS in a previous episode, and this describes pediatric acute onset neuropsychiatric syndrome, where you can have multiple different infectious triggers, commonly strep infection, mycoplasma, or Lyme disease or other tick-borne illnesses. And these kids get new onset, very severe psychiatric symptoms, often restricted eating, OCD. I can see psychosis. I see new onset suicidal ideation and extreme emotional lability and dysregulation. So in those settings, antibiotics also help. But if the patient presents very severely and antibiotics are not doing the trick, oftentimes we go to immunomodulatory treatment. such as IVIG, for example, and that can be very helpful. So I guess the short answer, the longer answer to the question is that I think it's probably a mix of both. I think it's both persistent infection and also immune dysregulation at play in these complicated cases, and especially when it comes to like a chronic infection picture.
Shannon, how do you straddle that line between psychiatry and neurology? Because I feel like that's not necessarily. I have a psychiatrist, and we have never talked about long COVID, but yet he's treating my symptoms that have, I guess, manifested as a result of my COVID infection. So I feel like you're really awesome and special because you operate from these two very important perspectives that do intersect and are important in addressing care. So what would you say to medical students who maybe haven't considered this perspective before?
Yeah, well, first of all, thanks for that comment. And second,
yeah, of course.
I would say, I think that the field of medicine, and in particular psychiatry, has suffered in a lot of ways because I think medicine sort of views things very dichotomously in terms of something is like strictly psychiatric or strictly neurological. And if we don't have answers to it, then we're just going to put it in the psychological, psychiatric, mental health realm and kind of just like leave it there and not deal with it. But from my vantage point, I see it as brain inflammation. Like it's the brain and there's inflammation there. And in some people, we see more neurological type symptoms. And in other people, we see more psychiatric. And oftentimes we see a mix of both neuro and psychiatric. So I really don't think that there should be such a distinction. I mean, obviously, that being said, it's important to connect to a human being on the human level. And patients who are going through this, they can be suffering a lot, not only because of their symptoms, but because of invalidation from the medical community. So it's super important that they're able to connect with a professional to talk about their inner life. That's something sort of separate. So that's where having a therapist or a psychiatrist that you can build a relationship with and trust and confide in is hugely important. But when it comes to understanding the actual biological mechanisms at play, I see it from a very biological perspective, just because I have this experience of seeing all these people who literally give me this story like, hey, I was all good until like November 14th on Tuesday, and I woke up and like my world changed. That's a very biological phenomenon.
Absolutely. Yes. And so I want to get into the biology of this. Mike, you've done work on the vagus nerve, like amazing work understanding the vagus nerve. And can you tell us about the vagus nerve's role? What does it, I mean, I'm sure the medical students know, but I guess to review, what is the vagus nerve? But maybe you could describe it in the context of post-acute infection syndromes.
Yeah, I mean, a lot of the medical curriculum probably won't go over some of the newer findings and things like that. So it's sort of worth thinking about. So, when you inject a rodent, let's say, with bacteria or inflammation or something that mimics bacteria like lipopolysaccharide, the rodent will act sick. It won't socialize as much, it won't run as much, it won't eat as much, it won't be receptive to a mate. It's called the sickness response or sickness behavior. And the reason for that is so that energy is preserved in order to fight this pathogen or infectious challenge or other challenge. That is true unless you cut the vagus nerve. You have to cut it low or else you'll just kill the animal. But if you subdiaphragmatic, and then the brain doesn't find out that the body is sick. So the rodent will act more normal. There's some aspects of the sickness response that will continue, but most of the aspects won't continue. The reason for that phenomenon is that somewhat large inflammatory molecules like pro-inflammatory cytokines, first of all, they're produced largely locally. They're called interleukins, which means among white blood cells, meaning that they're mostly paracrine and autocrine signalers. They don't really usually function like an endocrine molecule that flows across the blood-brain barrier like a steroid hormone. So the brain needs a diffuse sensory organ that can detect somewhat local inflammation to say, hey, you have an infection, an inflammatory process in the lower left lobe of the lung, say. And that will cause the whole organism to feel sick, to go to bed, to rest, to not use energy in order to fight this pathogen. And, if you look at human illnesses, we all have the experience of, if we have the strep throat or the flu, you feel kind of tired, you're a little bit, cranky maybe, you don't eat as much, you don't feel like socializing right. Well, that's really interesting because I said strep and flu, which is a bacteria and a virus, very different organisms, but you have a somewhat preserved response, which is part of the innate immune response. So it's the broad response to all organisms, and that is the sickness response. And we think that that is at least part of, I would never argue that it's all of, but at least part of what people with these sort of infection-associated complex chronic illnesses are experiencing is an ongoing sickness response. And that may be because there is signal that's constantly bombarding a vagus nerve, which may be sensitive.
That's very fascinating. And so is this the vagus nerve sickness response? Do you believe it's exacerbated in post-acute infection syndromes? Potentially?
Yeah, I mean, it's an empirical question that's difficult to answer in a living human being. The techniques are not there. We're trying. We're trying to do that using, ultra high resolution fMRI, but the nucleus where the vagus nerve enters the central nervous system is tiny in the back of a brainstem that moves when we breathe and when our heart beats. So it's a tough thing to study, but that is our hypothesis of one mechanism that's contributing.
Wow. Okay. So I guess when you're looking at it from a superficial level, if someone came into the office and whether it was brain inflammation or vagus nerve, would you call it vagus nerve dysfunction or vagus nerve?
It's hard to know what to call it because it's kind of doing its job, right?
Yeah.
The problem is that there's something persisting that's driving an inflammatory response.
Okay, so superficially, that patient might look the same regardless of what's going on, I guess, under the hood, we could say. So how do you approach this? I think largely people tend to treat symptoms first because people are suffering. And if someone's coming to you and saying, hey, I'm feeling anxious or depressed, it would make sense for a doctor to say, okay, here are some antidepressants or anti-anxiety medication. But how do you go deeper than that? What questions should doctors be asking to make sure that they're getting to the root of treating the issue? Can they order any tests? Are there any tests available that they can order?
It's a little bit different for me because most of the time when people contact me, they're actually not contacting me just for my psychiatric services alone. They already suspect that there might be an infection at play, and that's potentially because they've gone down the psychiatric road for months or years and things may have gotten worse, or maybe they've talked to family or friends and they've told their story to them, and then someone said, hey, have you thought about Lyme disease, or have you thought about PANS or PANDAS? But I would argue that every psychiatrist, depending on the situation, if someone is coming to you with kind of a more typical anxiety or depression presentation where it's not necessarily new onset, there are other outside triggers, and there's not maybe multiple psychiatric symptoms, and there's no history of infections, that I don't know that a patient like that would need a comprehensive medical workup. But certainly if you have a kid who's presenting with a radical, severe, new onset psychiatric symptom or symptoms, and there's any sort of remote history of infections, I would argue that they deserve kind of the full workup. I'm practicing in New York. We're surrounded by Lyme endemic areas. This is like a major problem here in the Northeast. So I would argue that anybody admitted to a psychiatric unit should have some basic infection infectious workup testing done. But when someone comes to me, for example, I usually look for pretty much everything you can get in the tick, which is about 10 different things, amazingly. I do testing for strep antibodies. I look for antibodies to mycoplasma, which is a respiratory pathogen that can also cause PANS type symptoms in kids. And then I do kind of a basic immune kind of profile. I look to see that they don't have any immunodeficiencies. So I would check a quantitative immunoglobulin level. I like to look at the vitamin D level because it plays a big role in fighting off infections. And for patients who have chronic infections or an autoimmune presentation, we like to shoot for a higher vitamin D level, like closer to 50. Most people are actually deficient in vitamin D. So it's these kinds of things. It's kind of checking everything from an immune standpoint. I can often detect immune deficiencies or people with kind of strange immune responses. And I think these are all just part of the puzzle. Also, the patients who I often see, both kids and adults who've had a history of infections, they have they're in an inflammatory state. So we see immune abnormalities as well. So a lot of these patients present with elevated thyroid antibodies, for example, in the context of this chronic infectious state. So I think all of this is super important to address sort of the whole picture of the patient.
Shannon, I have a question for you. You mentioned that you're in New York City, correct?
Yes.
New York City area. And you said Lyme is very common there?
Well, when I said that, I didn't necessarily mean New York City proper. Like,
okay.
You live just in Manhattan and you're just hanging out in the concrete, then no, like you're probably not at risk for much. But most people, for example, I had one patient who a couple of years ago I saw, and she basically like lived in New York City her whole life. She never like went outside to green areas at all. And there was an isolated incident where, an episode, she had a fun afternoon planned and they went to the Hudson Valley and they went apple picking. And the one time in her life where she goes out into the grass, she gets a tick bite and she gets an obscure tick-borne illness called Borrelia miyamotoi, which ended up affecting her hearing. And it was a wild story. Like she never ever kind of left concrete. And then the one time she does, she gets sick. So the point is that like, if you hike at all, if you ever go to your friend's backyard in New Jersey or Connecticut, like you're going to be potentially exposed. Long Island has a huge problem in terms of tick-borne illness. So it's kind of everywhere, unless you're just like confining yourself to your apartment, which I wouldn't recommend.
I think that's a big misconception. And that's kind of what I wanted to get at was like, you don't have to be like hiking in the mountains to get bitten by a tick or like, get a disease from a vector. Like you could go apple picking with your friends. Like it's more common than many people assume. So how would you know? I've fortunately never been bitten by a tick, as far as I know. But how, I guess, would people know? You would know if you were bitten by a tick. No?
Most patients I see never ever found the tick. They never had the classic like bullseye rash or EM rash is what it's called. And they had no clue. Like, for example, another patient who I'm taking care of, a 15-year-old, they live in Brooklyn. They live in a like apartment complex. They don't really have any outdoor experience except like a year ago, they went to Cape Cod on vacation. Super sad story. And a few months later, the kid presents with new onset neuropsychiatric symptoms. They eventually got to me. I did the full workup, and they have another obscure tick-borne illness and also Bartonella, which is another infection that you can get not only from ticks, but you can get that from cat scratches, from fleas, lice, and potentially house spiders. So the point is that like most people that I see, they have never seen the tick. But the majority of patients have like some exposure risk So they, in the summertime, they maybe go up to the Catskills, for example, or spend time in the Hudson Valley. And so pretty much everyone has probably been, if you live in the Northeast, you've been potentially exposed at some point. So it's probably worth checking.
A tick nymph, Raven, a tick nymph is like the size of a poppy seed. They're tiny, and they often like the hairline or, things like that. So it's not easy. Some people have the obvious bloated thing with the big red circle around it, but, people with darker skin or people that have a nymph, it's tough.
Well, my mind is blown, and now it's very alarming that I've never been tested for any of this. And now I can imagine how relieved people are to finally get to you, Shannon, where they can put all the pieces together because, wow, oh my gosh.
Yeah, so you had asked about sort of like the shared consequences in people and that sort of thing. So yeah, I mean, I think it's there are overlapping symptoms, obviously, in a lot of people with, long-term infection-associated chronic illness. I personally think that it does matter what is driving it and what is onsetting it. If someone is in debilitating pain and they get relief from IVIG or some immunomodulation, like I get it. I understand that is something that you would want to, help relieve the patient, suffering. But, to me, if there's a persistent ongoing driver, then instead of just constantly clearing smoke, we ought to be trying to put out fires. And that's a really difficult thing because in testing, you kind of have to know what you're looking for. There isn't really a test that says, tell me what you got, like Star Trek, where you just scan someone and it tells you, right? So there, people are working on some things that are a little less biased with, things like metagenomics. But generally speaking, you have to have a question and find out, does this person test positive for X, Y, Z? Sometimes it's antibodies, sometimes it's genetic material. It's not always in the sample that you're looking in. So testing is a whole thing. But yeah, I completely agree with Dr. Delaney that it's a massive, terrible scandal that neuropsych patients aren't just getting a panel of tests. There's a bunch of things that we know drive problems. The CDC estimates that 11% of Americans are positive for T. gondii. We know that can drive neuropsychiatric symptoms. So the person that is homeless and talking to themselves that people step over when they're going to see Phantom of the Opera, they may have a T. gondii infection in their central nervous system and they've simply never been tested. It's a scandal.
And so as far as, I guess, resolving these, I mean, could it in some cases be as simple as taking a round of antibiotics?
That would be nice, but sometimes it is difficult. I mean, sometimes, I'm sure Dr. Delaney has seen this more than I, that if a kid has pandas and you address the strep infection, they can get better really rapidly. In some cases, just like she talked about earlier, it isn't just a single round, unfortunately. Oddly, we know that in veterinary medicine. We know that if a horse doesn't get better from Lyme disease after an initial round, we try another type of approach, another type of antibiotic. Some of these are bacteriostatins, not bactericidals. We try something different. But in humans, we kind of say, well, 10 days or you're probably just need therapy. And I don't agree with that.
Wow. Okay. So it sounds like there's quite a bit of challenge when you're addressing these things. How do you, I guess, what are some ways that doctors can address some of the stigma around this? Because I think mental health, there's some stigma around it. And even in the treatment room, like, I guess when at least when I've spoken to providers, there's kind of like this rush to treat with like SSRIs or things like that, and there's even a stigma in the treatment room where the doctor kind of wants to just gloss over everything and be like, you have generalized anxiety disorder. And I'm like, but I never had it before. So I guess what can doctors do to be a part of the change to shift this narrative away from a stigma and really helping the patient get some solutions?
I would say if doctors are committed to being at least like open-minded and educated about sort of new advances in the field and really listening to their patient. Most of the patients that I see who have a history of these infections contributing to their psychiatric problems, unfortunately, psychiatric medications don't usually help. I would be all about psych meds in this setting if they actually help the patient get better, but more times than not, they can exacerbate the situation. So I would say for a psychiatrist, or honestly, a lot of therapists who aren't trained as medical doctors, good therapists who are listening to their patient can kind of put things together. They often will be the ones telling the patient, like, listen, this doesn't sound like a typical psychiatric presentation. And you also are very fatigued and X, Y, and Z. Maybe you should think about seeing a different doctor, or maybe you should think about a more complex medical workup. So I would say that anyone who's presenting like intractable to psychiatric medications, more than one, multiple different classes, and if they have any other more atypical symptoms that sort of like go outside the normal psychiatric realm, you should think about potentially an infectious or an immune contribution.
Yeah, I mean, I totally agree. And also it's worth noting that, many SSRIs do modulate glia, the neuroimmune cells in the central nervous system. The serotonin theory of depression is a little bit weak. I mean, that's probably part of the story, but it certainly isn't the whole story. So I kind of think of it in a concept called equifinality, where there's an endpoint that you can reach from many different directions. You can certainly end up depressed from a bad breakup, but you can also end up depressed after a concussion, or if you have a persistent illness of some sort, the inflammatory contribution. And doctors ought to be working backwards a little bit instead of just sort of following a very oversimplified decision tree where you see depression and you just throw some Prozac at it. Certainly therapy would benefit all of us, right? But, if you've got this powerful driving neuropsych symptoms, the brain is an organ that can get sick, like the pancreas gets sick, and that disrupts, digestion, metabolism. That's kind of easy to understand. But when the brain gets sick, it makes us act strange and have, abnormal, inappropriate emotions and thoughts. And that's a little bit harder for people to wrap their heads around. But you have to kind of think of like, why is this organ sick?
Thank you.
I wholeheartedly agree with that. And I would just say, related to SSRIs in particular, I do have some patients who are on SSRIs. If they come to me and they're like doing relatively okay on it, I don't mess with success. But overwhelmingly, in the context of kids who get these infections, SSRIs can be very activating. When they have an active infection and they're given an SSRI, they often become very agitated, and they can develop like new onset suicidal ideation within hours. I see it.
Oh my gosh.
Yep. Really aggressive. Yep.
So I'm very reluctant to use SSRIs in that population, or if I do, I start them on very small doses, which is unfortunate because it's the first line treatment for a lot of the symptoms that these patients are experiencing, such as depression, severe depression, anxiety, OCD. So it becomes, it's just an added treatment, like complexity and difficulty in dealing with the treatment of these patients.
Mind blowing. Wow. Shannon, you mentioned staying up to date with the latest developments in this field. Can you, or Mike, you as well, are you all able to speak to any of the emerging technologies or like what advancements that are exciting to you right now, or do you foresee coming into fruition?
Yeah. So one of the things that I'm most optimistic about, because of the phenomenon of, most tests, you kind of have to know what you're looking for. So if you use like a PCR, right, to test for an organism's genetic material in blood, say, if it happens to be type, you have, a primer that what you're looking for, and it binds, and then you can amplify it. But if you don't really know what you're looking for, if you see someone that's really sick and you go, well, what's happening to that person? It's hard. Not all cultures culture everything. But, the metagenomics technologies, the sort of second generation in sequencing genetic material, I think is really promising, because you can sequence all of the genetic material in a sample. So, it took, 12 years for the first human genome to get sampled, and now you can do it in like 4 or 5 hours. You can also sequence all of the non-human reads in a sample. So you could take a tissue sample or a blood sample, and then run it against a library of known organisms to see if there's a match. So you could take a sample and say, in a somewhat unbiased way, it's got to match with the library. But I think that's one of the promising areas of testing that will allow us to find stuff when we don't even really know yet what we're looking for.
That's very exciting. And that's in development right now, or it
Yeah,
exists?
the technology is there, and some groups use it, but I think the ability for a doctor to do that is somewhat limited. There's a couple of companies that do that with, urine testing. So like UTIs are really complex. They kind of like set it up to make it easy for E. coli to grow in the culture. So they always think it's E. coli, but it's probably a lot of other things interacting like most of these issues. So some companies are already doing that, but I think that's gonna take off over the next 5-10 years.
It's exciting. Shannon, do you have anything?
I would just say that, yeah, I also think that metagenomics is quite fascinating, and it would be an amazing solution to these complicated patients that I see. It's not quite ready for prime time, as I know of yet, in terms of any tests that I can do like in an office setting and get answers pretty quickly. I think UCSF has a metagenomic kind of platform, but it's a little bit more research-based and hospital-based. So I think that would be incredibly exciting. From the tick-borne illness standpoint, there are some vaccines that they're working on that are like in the pipeline. I would say the one that I'm probably the most excited about is, I think some scientists at Yale are working on a vaccine that would allow people to have a reaction to the tick bite. So I think that would be an amazing progress, because that is more in the area of prevention. Because if we can have people, so what happens is when you get bitten by a tick, they actually release sort of an antiseptic type molecule so that your body doesn't even realize that you had the tick bite and doesn't itch, and you have no idea that it happened. So to my knowledge, this vaccine basically is prompting an immune response to the tick bite, which is kind of ingenious, because I think that makes a lot of sense. If you can aggressively kind of get it before it gets into your body, or, take a longer course of antibiotics at that point, that would be a huge key in preventing some of these infections. I would also mention, though, when we were kind of talking about how scary it is to walk outside earlier, I would emphasize that using insect repellent is not something that I think most people think about when they go on a hike or go garden, but I think it's a really important piece, and it's recommended by the CDC that anytime you're in any sort of tick endemic area, and in the Northeast, it's everywhere, you should be wearing insect repellent. They say something that has at least 20 or 25% DEET in it. And if you're kind of anti-DEET and you don't want those chemicals, there is a good product. I believe it's called Insect Repellent IR3535. I think it's a natural vitamin B derivative that's very good against, it's very good tick repellent. And they use it a lot in Europe for pregnant women and children. It has a good safety profile. So I tell parents that all the time, especially parents who are like, all these kids are going upstate and they're going to sleepaway camp. And I don't know that anyone is monitoring kind of that situation. But if kids are in that environment, they should be wearing insect repellent. You should be doing tick checks. At the end of the day, they should be showered. The CDC says every time you come in from outside, if you're in a tick endemic area, you should take off your clothes, and you should also shower, and you should be using insect repellent. So these are things that like most people aren't incorporating into their daily life that I know of, but I think they are important pieces to prevent infection.
Wow. Well, that does give me hope. And that's very interesting. Thank you. So we're wrapping up soon, but I would love to leave with some, I guess, well, first, is there anything that we didn't talk about that you would like to speak on before we wrap up? That's the best question.
A million things, I guess, but that was a good conversation.
Thank you. Yeah, so being that we're sending these students off with this knowledge and they're going to go on their own journeys, I would love for them to hear from you why you got into your research and your practice, and what words of wisdom do you have for them on their own journeys in this field?
I would say, so my journey was I think I was affected in very specific ways. So it's a good thing for me to weigh in on. When I was an intern, so around like 2009, it was right when NMDA receptor antibody encephalitis was being discovered. And this is a condition where you usually do have some prodromal illness, usually viral illness. And then a few weeks later, you develop rapid onset, usually first psychiatric symptoms, often psychosis. And then it usually progresses to extreme neurological symptoms. And these patients end up usually in the ICU with sometimes seizures and very extreme neurological symptoms. And this is a condition where it's an example of molecular mimicry involving the NMDA receptor, where this abnormal antibody is created. And because of this, you get these extreme symptoms. And I was super interested in the fact that here we have a very specific neurobiological event involving the NMDA receptor and an antibody. And most of these patients are presenting with psychosis. So being an intern, my first year as a psychiatry resident, I was super excited that maybe this is part of the key in unlocking some of the complexity that we see with psychiatric disease. And then I started thinking, how many people are locked in psychiatric units who actually have these immune problems going on? So that was the sort of the origin of my interest. It was just kind of good timing from that perspective. And then also this was the same time when PANDAS was like, a lot of people were talking about it. It was a little bit of a controversy, which it still is in some ways. And then directly in my clinical training, both my adult psychiatry training and my child psychiatry fellowship, as a psychiatrist, we would be called to see these complicated patients a lot in the hospital. And I always found myself not really agreeing with the psychiatric, like the attending psychiatrist viewpoint, who often would like say that something was psychological and attribute it to something that had happened potentially traumatically in their past, even though the patient wasn't even bringing this up. So I didn't agree with that at all. And I thought that was a failure of medicine on multiple different fronts in trying to help this patient in need. So that was what motivated me to go into doing more research. And that's why I pursued my research fellowship for 3 years, trying to better understand immune and infectious contributions to psychiatric disease. So I think I would recommend just to follow your passion. I mean, in this particular situation, I was super interested, but then I was angry based on what I was seeing in my day-to-day clinical world. And it felt like there was a huge need. There was an area of medicine that just significantly needed to be addressed. And I felt like someone needed to like play that role. And so that's what motivated me to go down that road. So I think everybody should just kind of ask those questions of themselves, like what rotations in either medical school or even residency, like what made them the most happy, what made them thinking when they got home, maybe what made them angry and wanted to make more of a difference in the world.
Thank you, Shannon. I just want to say thank you for what you do, because you play such an important role in the healthcare system. As someone who really struggled with psychosis after my COVID infection, there's nothing like losing your mind, one, and then being in a situation where no one hears you. Like, you're telling people, I'm sick. I'm not, like, this isn't due to any event, like socially, like I am sick and I'm losing it. And so I totally resonate with that. And as I was experiencing this, And as I was being faced with, oh my gosh, are they actually going to put me in the psych ward? I too was thinking, how many other people are in the psych ward that are sick like me and like
Yeah.
aren't being listened to or understood and just completely dismissed and being fed these really powerful psychiatric drugs. And it's a mess. It is a huge mess. So I personally thank you. And on behalf of all of the other patients who have struggled with this, like, thank you, because it gives us so much hope to know that people are on it and they care, and they're working on it. So thank you. Mike?
Thank you for your words. And
of course.
I'm sorry that you went through that. I can imagine it's probably one of the scariest things that anyone could ever go through in their lifetime, to feel like their mind is kind of like they're not fully in control of what's going on in their mind, and nobody is fully understanding it.
I know. I tell people now, I say, if you lose your mind, you lose everything. And you really don't. I didn't value mental health until I lost it. And now I'm like, okay, everything has to be in order now, because it can take one little infection to set everything off and your entire life will change. And you're lucky if anyone knows how to help you. So yeah, thank you. Mike, what you got for me?
Well, I just wanted to say that also what Dr. Delaney is doing is just brave, because there is an establishment of dinosaurs that don't even realize they're going extinct. And
Great line.
This is the way things are going. People will know that this is an important contributor to just chronic illness and to neuropsychiatric illness. In 20, 30 years, people will be pretending that they knew it all along. But what Dr. Delaney is doing now is brave, because you want to be half a step ahead in science. You don't want to be 2 steps ahead, and it's difficult. So, I mean, from my perspective, I got into the general topic because of a sick friend. I essentially caught up with a friend from high school. What have you been up to? I've been studying neuro, blah, blah, blah. I had to drop out of early acceptance law school. I got really sick, maybe like 8 months prior. I had a really severe chickenpox. I don't know if that was related, but now when I stand up, I get really dizzy. I can barely make it out of bed. They're calling it chronic fatigue syndrome. I don't really know what's happening. She wasn't mentally ill. It'd be okay if she was, but she wasn't. Like, she wasn't particularly depressed or anxious. She was just sick. She did not have a functional neurological disorder. She was sick. And I started to look and recognize that, I'm going to throw some people under the bus here, but the research on that topic wasn't very good. Some of it was just simply methods weren't developed yet, but there just weren't a lot of really cutting edge good research programs. And similar to Dr. Delaney's, being there at the right place at the right time with an MDA receptor. I was at the University of Colorado, where the vagus nerve's function in neuroimmune signaling was being uncovered by scientists like Lisa Goller and Linda Watkins. I was thinking about my sick friend and thinking about how powerful nerves are. And if you have an infection on a pain transmitting nerve, you get debilitating pain. Well, maybe if you have an infection on a sickness transmitting nerve, you have debilitating sickness. And so it sort of like sent me down this path of studying the topic. I don't even mean to get into it. I was studying PTSD, hoping that I would write some stuff and the field would take over, but they never did. So I, similar to Dr. Delaney, I recognized that someone had to do it. And that's part of the reason I'm still involved.
That's a great story. And
that's absolutely fascinating.
Thank you for your words. And I think that another huge problem, it's amazing to have this conversation between a clinician and a basic scientist, because it rarely happens in medicine. And we're so siloed. I mean, it often doesn't even happen between 2 doctors because everybody is so uber specialized. But I think really to move the needle, we need more conversations like this between basic scientists and clinicians, especially when it comes to devising like clinical research trials and studies and things like that can benefit patients. So thank you.
And I would say also, like, in terms of like a take-home life lesson for medical students, humility would be a good one. Sometimes the answer is, I don't know. It's not that I ran the test, it was negative, and therefore they must be hyper-focused on their body or mentally ill. Like, that is assuming that you know something because the other things got ruled out, so you must know that. And then you start digging through their past and saying, oh, did you have this experience when you were a kid or something? And sometimes the answer is, I don't know. And you have to have some humility. We don't know a lot about the human brain and body. And it's just, it's really hubris to think that we always have the answer.
Totally agree. In fact, we talked a lot about that at the previous segment in terms of doctors need to embrace this aspect of uncertainty a lot more, and they have difficulty with it, I think, on many levels.
Yeah, I think they're trained to project competence and confidence,
exactly.
which helps people feel, more, okay, the doctor knows what they're doing. But, that is also how you send someone home with the wrong answer.
Precisely. Yep.
Absolutely. Thank you both for your insights and perspectives and your knowledge and your teaching. I really enjoyed speaking with you both. I can't wait to do it again at some point. But the messages have been so consistent through each episode, no matter where the background is. Every person, scientist, healthcare practitioner alike, everyone's saying, listen to the patient. Listen to the patient, hear the patient. Don't be afraid to try new things. Don't assume things. And I'm excited I can't wait to hear what the medical students have to say when they listen to these, because it's been very inspiring to hear you all say these things. So yes, I guess that's the end of our episode then. Thank you for listening to this episode of Raise the Line. I'm your host, Dr. Regan Baxter, and we've just had Dr. Mike Van Elzecker and Dr. Shannon Delaney give some great insights into post-acute infection syndromes and specifically neuropsychiatric manifestations of these infection syndromes. Bye.